Welcome to the Cold Steel Surgical Podcast with your hosts Amir Farouk and Chad Ball.
Well, the summer has come and gone and we're back into the swing of things. We're really excited that in a couple of weeks, many surgeons from across Canada will be meeting for our largest national conference, the Canadian Surgical Forum. This year, it is in the lovely city of Winnipeg. This episode is a teaser for the type and the caliber of work that is presented at CSF. Dr. Elena Parvez presented this work last year at the Best of CSF 2023 research session. Dr. Parvez is an assistant professor of surgery at McMaster University in Hamilton. Her clinical practice is in surgical oncology. In this episode, she presented her work on adjuvant radiation therapy among immigrant versus Canadian-born women with breast cancer. This year we'll be recording live at CSF, and we look forward to meeting many of you. We'd love to hear your feedback and suggestions for content for the upcoming year. And as always, you can also send your thoughts and feedback to podcast.cjs@gmail.com. Dr. Parvez, thank you so much for joining us on the Cold Steel Podcast. It's an absolute pleasure to have you on the show. Thank you so much for joining us early on a Sunday morning to talk about your research.
Thank you so much, Amir, for having me here. It's really a pleasure to be here and very excited to share this work with the Canadian audience.
Well, just for our listeners, this is part of our CSF, Best of CSF 2023 series that we've been doing. Dr. Parvez's research was, again, one of the presentations and projects that I think a lot of people really enjoyed and had a lot to think about after listening to Dr. Parvez's research. So before we kind of dive into the project, which was on disparities, and correct me if I'm wrong, but essentially on the disparities in receipt of radiation for breast cancer patients among immigrant women. What was the impetus for doing this research?
When we think about immigrant populations in Canada, they face a number of challenges, I would say, when navigating the healthcare system. And these challenges really occur at the individual level, at the healthcare system level, and at the level of broader society. So some of these challenges and barriers are some of the cross-cutting social determinants of health. So these are things like poverty and race and education levels and that sort of thing. But there are a number of factors that I would say are a lot more specific to the immigrant population. And so those are things like, sometimes challenges with language fluency or challenges with, having a family or community support nearby. And so in my clinical practice, I've noticed that, because of these challenges and barriers, sometimes, immigrant women weren't necessarily able to receive, some aspects of care that we would consider standard of care. So, our study team really wanted to explore if there are any differences in the quality of care that immigrant women and Canadian-born women receive when it comes to breast cancer care.
That's fantastic.
So just for a bit of background, so Canada is a very diverse country in terms of its ethnocultural makeup. And first-generation immigrants comprise about 23% of the Canadian population. And that's actually the largest proportion of the population made up of immigrants of any of the G7 countries. And we actually expect that proportion is going to continue to increase over the next number of years. So clearly, immigrants in Canada are a very large segment of our population, and we need to understand healthcare outcomes in this segment. So I briefly talked about some of those factors that can maybe make it more challenging for immigrants to access the healthcare system. And barriers can occur at the level of the individual. They can occur at the level of the healthcare system. So here we're thinking about things like, potentially access to translators or access to written materials in the patient's language. And then at the level of broader society, so what sort of supports and infrastructure is available for immigrants coming to Canada in terms of, things like finding a primary care provider, having access to medical services. So as you mentioned, my clinical practice, it's in breast cancer. And so what I wanted to understand and our team wanted to understand is whether immigrant women in Canada with breast cancer have the same outcomes and receive the same quality of care as Canadian-born women. So the objectives for this particular study was to, one, compare the proportion of immigrant women compared to Canadian-born women who receive adjuvant radiation after breast cancer surgery, and also to compare the time from surgery to receipt of adjuvant radiation. So as we all know, adjuvant radiation is a very important part of management for breast cancer. So this was a population-level retrospective cohort study which used linked Ontario administrative databases. We included all women who were greater than 18 years of age and diagnosed with stage 1 through 3 breast cancer between 2010 and 2016. We excluded any women who did not have provincial healthcare plan coverage, those who had in situ breast cancer only, and those with incomplete staging information. When we did our time between surgery and radiation analysis, we also excluded any women received chemotherapy between surgery and radiation, as this would have impacted wait times. So for this study, just a little bit about how we actually defined immigrant. We used the Immigration, Refugee and Citizenship Canada database. So this database was incepted in 1985. So essentially, if you came to Canada from 1985 onward as an immigrant, you would be registered in this database. But if you came to Canada prior to 1985, or if you were born in Canada, then you wouldn't be in the database. And so we classified these people not in the database as Canadian-born or long-term resident. So some of these women certainly would have been immigrants, but they would have arrived to Canada prior to 1985. We collected data on a number of other important covariates. So we collected age, neighborhood income quintile, geographic location. We looked at neighborhood marginalization index, so things like material deprivation, neighborhood instability, neighborhood dependency quintiles. We collected information about comorbidity, whether or not they had a family physician. We also collected data on stage, biomarker profile, and then what type of treatment facility they received their care at. So whether it was a regional cancer center or not, and also volume of breast cancer patients at the treatment facility. With regards to the immigration-specific variables that we collected, so these were the variables that we had for our immigrant cohort. We did also look at things like immigration class. So if they came to Canada as an economic immigrant, a family class immigrant, or a refugee, their length of stay in Canada, so how many years they've been in Canada prior to their diagnosis, their region of origin, and then also language fluency at the time of landing in Canada.
So you said you use this database to find immigrants, but then you were able to capture Canadian-born long-term residents, even if they weren't captured in this database. Am I understanding that correctly?
The Canadian-born long-term resident group. So we were able to collect the information on the covariates, so things like, age, stage, biomarker profile, where they were treated, et cetera. We just don't have the variables that are specific to the immigrant cohort. So the things like immigration class, length of stay in Canada, region of origin, and language fluency. But for the Canadian-born cohort, we've got all of the sort of baseline demographics. Yeah. Got
it. So is it possible that there were immigrants in the Canadian-born group that weren't captured in? Like, is it possible that you have some immigrants in the Canadian-born or long-term?
Oh, for sure. Yeah. Well? So for sure. So there's definitely immigrants in this group. So the Canadian-born / long-term resident. But they would have arrived, prior to 1985. So certainly a big assumption made there about those groups. But they would have arrived now close to 40 years ago, and so we've made some assumptions here that they would have, perhaps integrated into the environment here in Canada and acculturated and would have some experience navigating the healthcare system and that sort of thing. So we've put them in that Canadian-born group, but certainly I agree with you. It's a big assumption because, they may still, despite, being in Canada for more than 40 years, they certainly may still face a number of challenges. So here with our cohort, we had about 54,000 patients who were included. About 13% of these were immigrants. When we looked at the two cohorts, they basically differed on all of their baseline demographic measures. So immigrants were younger at diagnosis. They more often had stage 3 disease, and they more often resided in the lower income quintile neighborhoods. So on our multivariable analysis, we found that immigrants were significantly less likely to receive radiation after breast-conserving surgery compared to the Canadian-born/long-term resident cohort. And the odds ratio here was 0.86, and the 95% confidence interval, the bounds were 0.78 to 0.95. On our multivariable model, there were a number of other factors included in that model that were significant, and those were things that you might expect. So, for example, things like age, stage, whether or not they were treated at a regional cancer center, were some of the factors that were highly significant in the model. We then looked at whether or not there was a difference based on receiving radiation after mastectomy, and we found actually no difference between the two groups on portion receiving radiation after mastectomy on the multivariable analysis. We also looked at wait time. So we looked at time from surgery to receipt of radiation on the univariate analysis as well as on the multivariate analysis. Immigrant women waited a bit longer for their radiation compared to the Canadian-born women. So on univariate analysis here, you can see that the mean difference was about 13 days or so between the two groups. And again, when we adjusted for a number of other factors in a multivariate model, it still was a significant difference. We also looked at time from mastectomy to radiation, and here we found no difference between the two groups in terms of either the univariate or the multivariate analysis. So we did a little bit of exploratory analyses to try to understand why we might observe some of these differences. We looked at time from breast-conserving surgery to radiation based on region of origin. And I just want to stress that this analysis here should really be considered exploratory. We're just trying to identify some patterns here. But you can see here that, some of the subgroups had relatively small amount of patients in them. So, for example, the subgroup Sub-Saharan Africa, only 197 patients included. The subgroup here, US, Australia, New Zealand, only 97 patients included. So this really is exploratory. But I think that regardless, the difference is a little bit striking. So you can see here that there are some groups that are waiting longer. So, for example, South Asian women from Sub-Saharan Africa, and women from Latin America and the Caribbean, whereas there are some groups that, have significantly shorter wait times. So I think that this is something that needs to be studied further. We did also look at time from breast-conserving surgery to radiation based on length of stay, immigration class, and language fluency. And here we didn't really observe any clear discernible patterns. So in summary, our study found that a lower proportion of immigrant women undergo radiation after breast-conserving surgery, and immigrant women have a longer wait time for adjuvant radiation following breast-conserving surgery. And on exploratory analysis, we did observe some differences based on region of origin, but this really does require some further study to clarify. So I think, one of the major strengths of this study is that it's a very large population-based cohort, and we accounted for and adjusted for many important covariates. And regardless of, including all of those covariates, we did find that immigration status was still a predictor of having less radiation and having a longer wait time to radiation after breast-conserving surgery. Population data like this is very important because it can help us understand patterns of care. We really can't make any conclusions about causality, right? So we really do need to investigate this pattern a little bit further and see, one, if we can validate the findings at the local level. So, for example, within our hospital system, and then two, to try to understand why we might be observing these differences. So, in terms of next steps, one of the things that we are going to be doing is a qualitative study where we're going to ask newcomers some of the potential barriers that they encounter in accessing care for breast cancer. So hopefully this will shed a little bit more light on that. We are using the same population data set that we've created, the same cohort here, to look at a number of other outcomes. So not just time to radiation or receipt of radiation, but also things like wait time to surgery, reconstruction rates. So after mastectomy, having breast reconstruction, and then also looking at a symptom scale. So using the Edmonton Symptom Assessment Scale to look at differences there. So some of this work has already been published. For example, for the symptom scales, we did find that the immigrant women report significantly more pain after breast cancer surgery, and that difference persists despite adjusting for a number of other covariates. Some of the other data is not yet published, but we did, also find that immigrant women are less likely to undergo reconstructive surgery. We found no difference in wait time to surgery for the immigrant versus the Canadian-born women. So yeah, that's it.
Congratulations again on a really cool study. So I'm going to ask you a few questions about the results of the study. One question I have as someone who's early in my career and trying to get started sort of on the research side of things. What were some of the challenges in actually doing this research, and how long did it kind of take from inception, coming up with this idea, to actually having the results?
It's a great question. So I think I would say, with this type of work, the work is done at ISIS. So that's where all of the data is housed and where the data analysis is conducted. So I would say one of the big challenges there is funding. Especially as, early career researchers, I think that startup cost can sometimes be a little bit difficult. So my advice would be is that, if you have a good idea, something that you really want to pursue, find mentors who are invested in the same types of questions and are excited about your questions, and they can certainly help guide you in identifying good funding sources to carry out your work. So I would say that was one of the big original barriers. But after we overcame that barrier, there are a lot of challenges working with population data. Population data this is administrative data that's not necessarily collected for the purposes of conducting research. And so there's a lot of, potential problems, I would say, with the data. So things like missing data or some assumptions that you have to make, I guess. And so I think with this type of work, you really want to make sure that you spend that time up front to define your variables, to define your outcomes well, because otherwise you're going to run into problems when you start looking at the analyses.
That's some fantastic advice. One of the things that struck me about the study is even the initial sort of demographic data about how these patients present is interesting. And it kind of reminds me of some similar patterns that we see, for example, in patients with Crohn's disease in immigrant, or actually even the children of immigrants. Like, they tend to have pretty significant and severe Crohn's disease. I'm just curious if you have any thoughts about, like, some of the things like, presenting with more advanced disease sort of makes sense, but even the fact that they're presenting younger, that's interesting. Obviously, this is almost speculation, but do you have any thoughts about what's going on there?
Yeah, it's a great question. So, I mean, as you said, some of the stuff like around, presenting with more advanced stage disease, I think that we probably have a pretty good answer for that. There's work that's been done that shows that immigrant women are less likely to get screened. And so certainly that could be contributing. We also saw in this cohort that the immigrant women less often had primary care physicians. So certainly that could be contributing to the more advanced stage. With regards to the younger age at diagnosis, I think that's a little bit, certainly it would be speculative for me to make any sort of comments about why that is, but it is something that has been observed in other similar cohorts, that the immigrant group has a younger age of diagnosis. I don't know why this is. I mean, one of the theoretical issues that could come up is related to how we define the immigrant group. So as you recall, anyone who came to Canada prior to 1985 was classified as a long-term resident. So it's possible that it could be, some bias in the data set where we're putting some of the older immigrants into the Canadian-born cohort. But at the same time, if you have an 80-year-old who immigrated after 1985, they should still be captured in our immigrant group. So I don't know. Is the bottom line. I don't have a good answer.
I think the striking thing for me too is, like, even, it makes sense that, I shouldn't say it makes sense. I mean, it's still not, it's kind of a sobering thing to hear that our healthcare system is in some ways failing the most vulnerable people in it. But, in some sense, maybe it makes sense that patients are perhaps not getting the radiation. But even the time delay part really is interesting to me, because, at that point they've decided that they want to have, potentially, at least in my mind, they want to have radiation, and yet there's still a time delay. What are your thoughts on what's going on with that process, and why does there still seem to be a delay even for the patients that just have decided to go ahead with radiation after surgery?
For the time delay, I think that there's probably a number of factors. I mean, I think a part of it may be related to actually making the decision to proceed and, whether or not multiple visits are required. I think part of it may also be around social supports. So, for example, if you have radiation for breast cancer, often that can mean, a 4 or 5 week course of treatment, 5 days a week. So people have to plan for that. How are they going to get to and from the hospital? Do they have to take, time off work and that sort of thing? And so putting in some of those supports prior to initiating radiation can be an issue if, especially if you don't have a community or a family here in Canada with you. Also, between actually surgery and start of radiation, there are a lot of appointments that happen. First you have to see your surgeon to go over the pathology results, then you have to see the radiation oncologist, then you need your CT SIM appointment. And so for each one of those appointments, I can envision a delay. So, we're asking immigrant women to navigate our healthcare system, and, we take certain things for granted. So, for example, leaving a voicemail about when the appointment is in English, right? So these are types of things that could conceivably lead to some delay.
Yeah, or even better when the people are supposed to get a notice in the mail. I love that, that way of notifying people. I think many listeners may wonder, well, how much does the role of culture play in this? Is there an element of, well, maybe in some cultures there's challenges about receiving radiation, and I suspect that's obviously outside the scope of this population-based study, but it sounds like your group is, well on their way to trying to investigate those questions. Do you have any thoughts about the role of culture and potentially how physicians might better interact with that if there is some cultural differences?
For sure. So certainly that can be a question. I think there may be some element of distrust about what radiation entails. Like obviously you can imagine sometimes people's only exposure to the concept of radiation is through information they might have gotten in the media, and obviously that can have some very negative connotations. So there may be some element about culture and distrust of what radiation is and how how it can be used as a treatment. I think that with our qualitative study, we're hoping to hopefully maybe shed some more light on that and understand that a little bit more.
As a practitioner who deals with breast cancer and perhaps has to deal with immigrant populations, how do you think we can better do it? What can we as physicians or a healthcare system do better to try to mitigate some of these challenges, whether it's cultural or system level? Like what can we do?
Yeah, for sure. I think it comes down to cultural competence, right? So we can probably do better in terms of ensuring that our healthcare workforce has some sort of training or education in cultural competence. I think that we can probably do better in terms of planning ahead for things like having a translator present for consultation visits, or even budgeting more time for that consultation visit. So definitely doing a consult through a translator takes more time than it does without a translator, right? And so, sort of thinking ahead about allocating the appropriate amount of time. I think as a hospital system, we can make sure that we have information available, written information available in multiple different languages. I think that those are some of the things that we can do to help address some of these challenges.
Thank you again for joining us on a Sunday morning to talk about your research. Really neat stuff, and we're all really excited to see where your body of research goes next.
Thank you so much, Amir. Pleasure to be here.
You've been listening to Cold Steel, the official podcast of the Canadian Journal of Surgery. If you have comments or questions, please email us at podcast.cjs@gmail.com. Thanks for listening.